Next is Sunil. Good afternoon, everyone. I begin by thanking the organizers for having me here. And as they said, I'm going to try and finish it a little sooner. So I will just begin by saying that this topic is more a food for thought for all of those who either take a blanket decision for a whole brain or a blanket decision for a stereotaxy when there are limited lesions. There is a lot more when you are deciding about what radiation modality to select for radiation in brain mets with lung cancers. So about 20% lung cancers will present with brain metastasis and about 40 to 50% will develop it later. Of course, we all know that the rates of metastasis are much higher in small cell versus the other histologies. And also within adeno, we have a higher incidence with the EGFR positive. Now, with better systemic therapy for these, we have a longer survival with a rising incidence of brain metastasis. If you look at a one-line answer, that is a blanket thing, I would say that extensive metastasis in the body and brain would be whole brain radiation with or without boost to the gross disease. If there are few sites of deposit, either in brain or extracranial, it would be oligometastatic with stereotaxy to address all lesions. If it's a brain-limited disease with multiple lesions, a whole brain with boost to the gross disease, and a few lesions, the definition of which is evolving, then surgery, oblique stereotactic radiation. But we have to read in between lines about the expected survival, the importance of QOL and neurocognition in this increased survival, histopathology, response to therapy, available options of systemic therapy, and the possibility of immunotherapy plus stereotaxy. These have led to a paradigm shift in decision-making for brain metastasis and selection of modalities. So what are the criteria for treatment customization? It began with the RPA, which of course was the most commonly used before it evolved to the disease-specific graded prognostic assessment, which the purpose of which was to estimate the survival, individualize it to the patient, take clinical decisions about treatment based on that, and use this information for stratification for future trials. So the graded prognostic assessment involved criteria like the age, performance status, number of intracranial lesions, extent of extracranial disease, and the site of primary, that is lung, breast, melanoma, RCC, and colorectal cancers. So these are primarily the cancers where a GPA would matter, not all of the cancers. Looking at the GPA for non-small cell lung cancer, we see that a score of 0, 0.5, and 1 is assigned to the different parameters in all of the GPAs. If the GPA score totals to about 0 to 1, the survival is about 3 months. If it totals to about 3.5 to 4, the survival is as high as 14.8 months. Now, on an average, if you would go to the older literature, we had survival as low as 3 to 7 months with brain metastasis, with a RPA 2 having a survival around 4 months and RPA 3 around 2.5 months, which is seen both in international literature and literature at Tata. But later on, it then changed with the molecular GPA coming into picture, which was published in 2017 in JAMA. This used, first of all, split the lung cancers into non-adenocarcinoma and adenocarcinoma. So a 0 to 1 score of GPA was a 3-month for lungs in total, but when split into non-adenocarcinoma in the duration of 2006 to 14 with the newer systemic therapy, it became 5.3 months. For adenocarcinoma, 6.9 months. And if you look at the 3.5 to 4 score, then it increased to 46.8 months. So that means there is a very long survival and you have to very responsibly take all decisions of the treatment that you're offering to the patient. So the assessment score or the worksheet to generate these scores is available online, and you have to actually just feed all the details to get the GPA score. The most important factors which give a favorable outcome are a 90 to 100% KPS, absence of any extracranial metastasis, and a positive status of the EGFR or ALK mutations. So the DSGPA actually has shown few nuances which were not there before in the previous GPAs. That is, the EGFR and ALK mutations show a much superior survival. They're also associated with a higher propensity of leptomeningeal disease. Number of brain metastasis is also an important factor. And extracranial metastasis, of course, which was already known, is important. For a score more than 3, there is literature supporting that addition of whole brain radiation to stereotaxy gives survival benefit contrary to the practice to avoid whole brain radiation. Now, accurate survival hence becomes crucial to take informed decision for prognostication. We also have an updated molecular GPA, which includes the PDL1, which makes the 3.5 to 4 score patient have a median survival of 52 months. This is further a lot many more things of the same, that we have a molecular GPA for leptomeningeal disease. With the current TKIs, we have a survival of as high as 17.7 months for a score of 1.5 to 2. So yes, the paradigm is significantly changing. It is also different for synchronous and metachronous malignancy, presentation of the brain mets. So if you look at a 3.5 to 4 for a metachronous brain metastasis, your median overall survival would step up to 66.5 months. Now, how do we make treatment decision? So there are different aspects. For the systemic therapy, we have treatment guidelines by the ASCO, SNO, and ASTRO, which is a combined guideline. We have recently published ASTRO guidelines, and there are certain articles which integrate these. So how have the guidelines evolved? To begin with, it's broken into two parts, that's symptomatic and asymptomatic. For symptomatic brain metastasis, of course, a poor performance status becomes BSC or a simple whole brain radiation. But if the patient continues to be symptomatic, surgery, if too symptomatic, if not, then depending on the number of lesions, we will select either a stereotaxy, definitely for a 1 to 3 up to 5, now evidence for even 4 to 10. And if it's more than 10, we prefer a whole brain radiation. The newer thing that has come in lung cancer would be asymptomatic brain metastasis. This will largely be dealt by Dr. Naveen in his talk. So I will just briefly make a mention that in the situation where you have asymptomatic brain metastasis, for histologies like non-small cell, melanoma, and breast, you need to customize and take a call. It does not straightaway remain as a symptomatic chart. What happens is that if you have a systemic therapy option in these, you have to take upfront systemic therapy or brain radiation, but that entails regular follow-up with MRIs, the treatment and availability of TKIs. So the cost and accessibility of TKIs, cost and accessibility of MRI, education and awareness to understand the same, and risk of precipitating symptoms in larger metastasis. These are the things which one has to bear in mind and has to be taken a decision as per the patient in front of you. So the ASCO guidelines say that for symptomatic brain mets, of course, immediate radiation has to be offered, either radiosurgery, radiation, or a surgical resection. But for patients who are asymptomatic, local therapy should not be deferred unless specifically recommended. One of those recommendations is for lung cancer. So they say for EGFR mutant non-small cell lung cancer, if osimertinib is available, local therapy may be delayed. It does not say it should be. Next is ALK rearrangement. Same thing. If the TKIs, the brain penetration TKIs, second, third generation are available, local therapy may be deferred. It does not say so for the arm where we are using pembrolizumab with pemetrexed and platinum. That is when we have no driver mutation. So for small cell, largely it remains the same, that we do a prophylactic cranial irradiation. There are trials going on to evaluate that subsequently when patient develops a metastasis with multiple mets, whether a stereotaxy is still something which can be opted for. And there are also trials evaluating PCI versus MRI surveillance post the initial treatment. So there's a certain article which says that for brain metastasis, for known brain metastasis in small cell lung cancer, stereotaxy is an option. But if you look at the ASCO guidelines, it still does not recommend stereotaxy. It recommends whole brain radiation. Talking about brain metastasis from non-small cell lung cancer, again, if it's a solitary brain metastasis and you need histopathological confirmation, or the patient is too symptomatic, you go for surgery followed by radiation. However, if that's not the case and there is a driver mutation, you have options of a TKI followed by surveillance, or TKI, which is coupled with stereotactic radiation. So there are multiple trials which have evaluated the selection of modality, that is whether you would be preferring to use a whole brain radiation with stereotaxy, consider omission of whole brain radiotherapy. And these trials have published the results. We'll be talking, I'll just show them in the subsequent slides. They are grouped on the basis of the GPA. There are multiple other trials which also show the same. The ASTRO guidelines per se do not specifically give a histologically or a lung specific guideline. It's more about when to use stereotaxy and what are the doses, which I will just kind of quickly omit because we are a little short of time. But speaking about a single metastasis in the brain, of course, if larger, we need surgery. Otherwise, we can go for direct stereotaxy if we don't need the histopathology, patient is not symptomatic. Upfront focal RT has shown a better local control when whole brain is combined with stereotaxy, but the subsequent trials have said that it should be omitted. Now, what is coming is that when we're talking of, I will be skipping these parts. since we're short of time. Now, the other part is that in patients who have undergone surgery and we do post-op radiotherapy, of course, we have a better control by combining, but there is a risk of leptomeningeal disease, which can be combated by using neoadjuvant stereotaxy. So that is another thing which is under evaluation, with 16 grain a single fraction given 1 to 3 days prior to surgery, reducing the chances of leptomeningeal disease. Whole brain, we all know, has more neurotoxicity, but though it is going out of favor, but the trials which are published as per the NRG Bean N09, with improving prognosis and systemic therapy options, we can conclude that using whole brain radiation plus stereotaxy plus hippocampal avoidance could be selected for molecular GPA4, which has also been shown by Sbrt in his trials, and the same is recommended. So for polymetastatic, right now, more than 10, it is still the recommendation of a whole brain radiation. And of course, neuroprotectors now, as per the ASTRO guideline, Mymantine is something which they have given a strong recommendation to use with whole brain radiation along with hippocampal avoidance, unless the tumor is located close by. And hippocampal avoidance has been shown to reduce the Hopkins verbal learning test to improve to 7% versus 30% deterioration at 4 months. And the NRG CEC001 has confirmed that whole brain radiation plus hippocampal avoidance plus Mymantine significantly improves the neurocognitive decline. So I think that's primarily for poor. The last slide is that for poor performance status, of course, we will select as per the quad style. We'll go for a whole brain radiation. Thank you.
Thank you, Upasna. It was a good lecture. Thank you. We now move